vertical integration session. We have the lovely Professor Dimity Pond with us today, who's going to be presenting on demystifying practice audits, what, why, and how. I'm Sandy from the education team, and I would like to start by acknowledging the traditional custodians of the lands that we all live and work on. I'm on beautiful Darkinjung land this morning, and I would like to pay respects to elders past and present. Just to let you know that this session is being recorded. Please feel free to send through your chats or to interrupt during the session because we do want to have this as very interactive as possible to talk about practice audits. And I'm also going to be putting Slido on at the end for evaluation. As you know, that's always a very important part of this process. So let me hand over to Dimity.
Thank you very much, Sandy. So practice audits. So we decided to put this on because it's practical, but also, and because I wanted to, and also because it's towards the end of the triennium, and with practice audits, you can get some CPD points. So it's worth thinking about it from that point of view. So I'll include some reference to that in this talk. And I'd really like it to be interactive because I haven't got a huge number of slides, and I really want people to think about what they might do in their own practice for a practice audit. And well, here we go. I'll do the, I have to let's try and make this work. Doesn't want to work, Sandy. Oh, there we go. Okay, so hopefully by the end of the session you'll be able to just, describe what a practice audit is, and thinking about clinical audits of clinical conditions, and also practice processes, like you recalling patient sort of processes, or even like booking patient sort of processes lend themselves to audits. Describe how it could be used for CPD points, I've already touched on, and also how you can act on an audit to improve something, which is another whole story actually, and not as simple as it sounds. So has anyone got any questions about audits that you want to raise at this stage? You'll have to yell because I can't see everybody. Or that you want me to touch on? Okay, I'll move on. Oh, okay, it's decided to do that sort of thing. All right, well, why do it? Well, the idea of an audit is to look at what you're doing in your practice, whether it be clinically or otherwise. As I said, you could look at billings or patient flows or something like that. So from the point of view of clinical, it's a great way to check if your patients are receiving standard care, and as you think they are. So, and for example, with cervical screening, since the new 5-year, once every 5 years thing has come in, I have no idea if I'm keeping my patients up to date. 5 years is a long time, and so if people come in, if they've received a recall, great, but I could probably be a bit more proactive about calling people. I think not everyone's getting it, and everyone's a bit confused about the new number of times or number of years between screening. So that's one thing, but there's many other standard care things that we should do. I think someone worked out that we could spend an hour and 45 minutes with every patient reviewing their standard care items if we wanted to. It's also a good way to check not just if they're receiving their care, but also if they're actually responding to it. So, for example, there's new blood pressure guidelines that have just come out from the state saying 130/80 maximum. A lot of my patients are way over that. So should we perhaps look at these people and see what we can do about that? Or, often when we see an individual patient, they're a bit stressed on the day and you think, oh, I'll get you back when you're less stressed. You haven't just had an argument, been kicked out of your house or lost your job or something. And it sort of gets lost in all the messiness of general practice. So it's good to do an audit and pick up all these people who, for one reason or another, their blood pressure is suboptimal and they might need their medications reviewed. And it's also useful for new care strategies. So respiratory syncytial virus vaccinations, which I always have to check with my practice nurse. Is this person eligible? Are they pregnant? She says, yeah. Oh, then they are. It has to be a certain number of weeks pregnant. So it could be that that we're missing some because we're a bit vague about the exact requirements and it's a new thing. And we don't want people getting RSV unnecessarily. So you could identify people who need a recall for their vaccination, and some of them will come. So there's lots of good reasons for your patients to do these audits. Anyone got any other comments or suggestions about that?
I think one of the things I find, Dimity, is that whenever we talk about the word audits, we often think about, oh my goodness, it requires so much work, and how do we actually find all the information to then
Yeah.
review all the data and be able to then actually, I find the actual common links or common trends that we actually are searching for.
Yeah.
So I would love to hear how we can actually do this in an efficient manner so it wouldn't be such an arduous task.
Yes. All right. Well, that's exactly what I'm going to do. So
Cool.
that's really good. Thank you, Gordo. You've led me nicely into the next bit of the thing. And we'll talk about the benefits for you and your practice. Oh, here we are. So actually for the practice, it provides a form of quality improvement. And practices, new practice standards, I don't know if the old ones did, require practices to do some quality improvement. So when you're being accredited, if you've done an audit, you'll be able to point to this and say, yep, we're doing quality improvement in our practice. It may be that your audit would attract PIP payment, depending, of course, on whether you're eligible and what the audit is, and you'd have to look up the eligibility for that. But certainly a quality improvement project makes you eligible for some PIP as well. So, and I don't know the details. Does anyone know the details about that? No.
Yeah, I'm not sure. I know that we do it. So before our recent accreditation, we had to, I think we honed in on making sure we documented smoking status. And I think at the moment we're working on recording BMI.
Yes.
So
Good.
yeah. And often our practice nurses help sort of run that as well. And we'll send figures out to the doctors, make sure we, add BMI in there because we might have weight in there but not their height. And yes, we sort of have a little focus every few months on what we're missing.
And actually, that could be a good thing for a medical student to do too. And maybe record and make a little project out of it. So I've seen students presenting smoking status as a little project that they've done. So yeah, so thanks, Georgia. That's exactly right. So and of course you do get PIP for having a medical student. And those are processes, Georgia. You're recording in your notes. So it's not direct clinical care. It's about recording information. So that's an aspect of audit that makes it a bit kind of different and seem a bit theoretical, but I think it's important for us to have those things. And the other thing about it is, if you're going to do something like blood pressure or hemoglobin A1C or even BMIs, it might, it might be a little bit of a trigger for all the doctors in the practice to agree about what they're going to aim for, or at least discuss. And I'm sounding very cautious because doctors are their own bosses and they have their own clinical judgment. But I think a discussion about what you think is reasonable is not a bad thing to have every now and then. So, for example, I'm thinking of a blood pressure target. If I said 130 on 80, I know I know what the GPs in my practice would say. They'd just look at me and go, "Are you being a professor again? I thought you'd lost that job, Dimity. Aren't you retired? Forget it. We're not going to do that. Can't get everyone under at 130 on 80." And then they'll walk off. So then what is reasonable? So those discussions are useful, I think. Any comments on that? Right. Okay. So there is a handbook that the college puts out, and I've got the link down there, and it's a guide from their continuing professional development handbook about developing an audit. So it takes you step by step through this, and I've quoted some of this. It's a bit longer than this, but it's not too bad to read, and it's quite clear, I think. And they divide them into mini audits and full audits. In a full audit, you actually act on what you find. In a mini audit, you just improve your recording or note how many people you've done a particular activity with. So it talks about an audit as an evaluation of a care or a process or a system, and that it's a quality improvement process. And it does talk a little bit about ethics and privacy. So if you're going to talk about this data, you need to be careful not to talk about individual patients' names or talk in a way that an individual patient could be identified. So within the practice, it might be all right, but once you get outside the practice, like in this talk, I'm going to keep my conversation about an audit that I did, which I'm going to talk about in a minute, fairly general so that you wouldn't be able to identify anyone. So if you're going to present at even a teaching session or certainly at a meeting, you just need to be sure to keep it very de-identified.
Can I ask a question? Sorry, my raise hand's not working. I don't know why.
And I can't see everybody. No, I can only see 4. So.
Oh yeah, I was just going to, because I often find this a tricky step in when you're not part of the university. So if you're a practice who's interested, you think, oh, okay, I'd like to do this audit, but actually, I might want to write this up and maybe submit it to AJGP. And I guess the tricky part, and I'd be interested for your advice on this, is if you're not a conjoint lecturer, how do you get access to an ethics department or a quality improvement exercise type approval? Like if you're a GP in the community who isn't a conjoint, or is there a way to get ethics approval, or do you need to become a conjoint or something like that?
I think for Newcastle, you need to become a conjoint.
Okay.
But of course, the college has an ethics committee.
Yes. Okay.
But I don't know if they do those fast track quality improvement ones. And in the old days, in the GP synergy days, they had conjoints in GP synergy that could put fast track through
on behalf. Yeah,
and that was really good.
Yeah.
And they sort of negotiated it all. And Recent went through that too, the registrar projects. Yeah.
Yeah. I think it's a very valid point. Yeah.
Yeah.
I think people don't realize that step, and maybe they gather this data and then present it at a conference or anything, but haven't realized there's that crucial step beforehand before you start to.
And in fact, this year, I'm chairing the research committee this year, and I helped to review abstract submissions for GP25 up in Brisbane at the end of the year, and I realised that we didn't have a clue about whether these things had been through ethics or not through ethics, and in fact I've created a stir. The college is probably going, oh, when's she going off? But I'm insisting that everyone gives us evidence of their ethics approval before we might give them conditional agreement that they can present, but we need evidence of their ethics. Otherwise, they could get into trouble, and so, of course, could we. So, yeah. And you only need one person who's been part of the project, didn't know it was going to be projected, and feels miffed that, they never signed a consent form, and and rightly so. And, they recognise their words in some qualitative thing or something. And that's not right. We can't do that. Okay. So I've got a couple of pictures from my trip to Prague a few years ago coming up. So because you can see a pattern there and you think, well, it'll be relatively simple. I can see that. So first you need to identify a need. What is going to be audited? And so define an aim for your audit, which is very useful, by the way, if you're going to present it. Or write it up for CPD. And then for step 2, you need to describe the method. How will it be done? And you need to audit your practice against either something that you're aiming for example, that 70% of eligible patients have had their 75 plus health assessment, or that 80% of our eligible patients have had their flu vaccine or something, or look at a standard like blood pressure less than 130 on 80, dare I say it, and I'm not going to aim for that. It's not realistic, but for some people it is, and then so you select a guideline or a standard and aim for that. So you need to have that in there, not just sort of waffly. We found this, so what does it mean? You need to have some standard to measure yourself against. And then you need to think about how you're going to collect this data. And in my practice, because I'm the slow doctor who bulk bills a lot of my oldies, I end up doing this myself, often this data collection. And I know how to make the computer spit out the data. And I will show you that in a minute. And then you need to think about the confidentiality. Okay, so now we're heading towards a more complex picture from Prague of the actual whole building, and that is what will happen by the end of your audit. You'll have a whole beautiful picture of something that's going on in your practice. So then you need to collect the data. So that is me sitting down for a couple of hours on a Saturday afternoon. I do Saturday morning surgery, and doing the data collection. A practice manager that we had about 3 practice managers ago was very good at doing that, and she could do it for me. But the current practice manager is not as cluey with things like that. Although I could sit down with her and show her. She's also really busy though. And you need to decide how you're going to collect this data. Are you going to scribble it on a piece of paper, or are you going to make a printout, or even just draw up a table? So you need to think about how you're going to record your data as you collect it or it might be that the way that you do the search on your computer will print out something for you that you can use. And then you need to analyze it, and think what you're going to do about it if you're doing a full audit. And then implement those changes. So step 5 for the full audit wants you to monitor your changes as well and see if you've made a difference. So, and that is really the point of an audit, to make a difference one way or another. So it's nice to do step 5. And according to the CPD handbook from the college, you can count 6 hours for a mini audit. And these are measuring outcomes points, guys. So sometimes we're still missing a few of those at this time of the year. I know I am. So you can get 6 hours worth in a mini audit, or 10 for a full audit. So obviously, if you're significantly less than that, you shouldn't claim it, but you won't be. You'll be more than that, probably, if you're like me. Okay. And I'm not clever enough to have been able to put this on a PowerPoint, but that is the little description in the CPD book, from step 1, identifying the need, through that step 2, describing the method, having it worked out in your head, actually doing it in step 3, and then in step 4, analyzing that data and thinking about what change you might make. I'm going to talk about an audit that I did in my own practice, but is there any question or comment at this point? Okay. All right. I found this beautiful picture of a very peaceful looking doctor having a croissant and a cup of coffee there. That's obviously not me, having arrived here thinking that my sound wasn't working. So I'll be much more peaceful now that I've been able to make this work. So I read an article about flu vaccination. And because I'm a bit of a dementia nerd, and I was doing some research on that when I was working at the uni, I'm interested in people with dementia and looking at their flu vaccine rates. And this article, which I've referenced down there, you can click on that and you'll find the article. It stated that people living in the community with dementia, with a diagnosis of dementia, are under-immunised for influenza. And in residential aged care, that may be the case now. I don't know if anyone here goes to resi care. It's apparently the rates have dropped in residential aged care. And certainly the facility I go to is no longer keeping influenza vaccines in the fridge. So you have to go to a whole lot of hassle to get it, to bring it in. And I'm sure I don't know what's behind all that. It might be cold chain monitoring and it's all too complicated and they're not going to do it anymore. But I think it could well have been behind a drop in immunisation rates in resi care. Anyway, there's probably complex. So I read this and I thought, I wonder if that applies in our practice. So this is asking the question, and so I checked the records. So using a search function. Now, this PDF about medical director, probably our practice has got MD, but I know you'll have a whole range of different software that you guys use. What I did was very, very complex, guys. I put into Google, how do I do a search in medical director? And it brought me to this. Actually, there's a whole lot of different links to instructions about that. And the one I've put here came from the old National Prescribing Service, and it does an equally good one for best practice. and it was just a very simple set of instructions. So it is not hard to do. And it's, I've actually copied it word for word here. Open Medical Director. Do not open patient records. First, locate the search menu, and it's the 8th one across, guys, So it's a real step-by-step. It might be a bit out of date now because NPS has unfortunately been closed down, but it's basically that simple. And then you do search, and you have a screen then when you do that search. In Medical Director, the screen has what disease do you want to look at or condition, what age groups, what doctors under which doctors' names of the patient, and male or female, and seen in the last 1 year, 2 years, 6 months, 5 years. So you can do a whole classify your patients very nicely, and you can look at smoking. If you're going to do a smoking audit, you could print that out and then go into each patient and update their smoking, or the drug and condition. In this case, I was looking at dementia, and there are custom sections too, where you can put in your own search terms, and then it says move your mouse down and click. So it's very simple. It's not hard. Any of us can do this. Only one of the other doctors in my practice is a nerd like me and would be interested in doing that. And she and I sometimes have a little discussion about getting the best out of this process. She had worked at the uni at one stage too. Anyway, dementia is terribly underdiagnosed in general practice, and I know that people don't like to put it down for a variety of reasons, partly that the patient or the patient's family don't want to see it there on the conditions, the medical conditions list, and you're relying on your list of documented conditions, which is always full of holes. We're all like that.
Just a question, Judy. Sorry.
Yeah.
Do you search for other terms as well, like mild cognitive impairment? Alzheimer's.
Yes. So you can do a search which says dementia and Alzheimer's disease and mild cognitive impairment and memory issues and vascular problems, dementia, and cannot remember things. But sometimes people write the oddest things in that that list.
It is.
Oh,
and that's a major
an MSc less than 24,
Yeah.
Sorry.
Oh, sorry, I was going to say, yeah, that's what I found with this is that the major problem is the entries. And so one quality improvement activity for a practice is to make sure that you're using the pre-designated diagnoses in the practice software. So, and hopefully they're based on ICPC codes or similar. But so like the people aren't just typing, headache or well, that's probably not a good example, but funny turn or something. They go no syncope, or they say because then it makes your search function so much better. But yeah, because otherwise you're going exactly like you said, and hoping you pick up all the patients.
That's right. And then you might find a whole bunch of them that you hadn't thought of before. Yes. I agree with you. And I guess our country is moving to be wanting to use our data more. And I guess that might mean that it would be much more accurate for any government initiatives that trawls around our data, if we stuck to some common ways of describing things. But dementia, like a number of other things, has a whole lot of emotive issues around it. People don't want to write dementia. They don't want Alzheimer's disease on there. They're okay with writing. I find MMSE less than 24 doesn't faze them because they don't totally understand what that means. And that's helpful as a communication tool when you're writing a referral, it's helpful for the other clinician, hopefully. So So it's tricky. There's all sorts of reasons. And one of my colleagues was trying to do this for ischemic heart disease. And you'd think that would be less emotive, but there were so many different terms and she couldn't get the doctors in her practice to agree on what is ischemic heart disease, angina, heart failure, cardiac issues, So people don't like heart failure. They get upset about that. Yeah. So anyway, I found 65 people with a dementia diagnosis. So I could have done a whole search string, but I actually didn't, because I have done that before and I know we've got about 80. And I had my 2 hours on a Saturday afternoon and I was just limiting it. So then I went into each of those 65 people. Now, I'm sure that anyone with a techie brain would be able to do that non-manually, using some system, which we probably got on our computer too. But I just went into each of the 65 people and looked at their immunisations to see if they'd received the flu vaccine. So I needed to record that. So I had a list of those 65 people and I printed it out so that there was space for me to record whether or not they'd received their flu vaccine. And this was at the end of June, 2023 it was. So you'd hope by the end of June everyone would have had their flu vaccine. So I'm still finding people who haven't now in August, but still. And I found that only about 30% of the patients with dementia had been immunised. And I know that about 50% of our patients overall had been immunised for flu. Eligible patients over the age of 65, it was that I was looking at. So there was a need. That's quite a lot less than the average over 65-year-old in our practice. Any more comments? Okay. So then I went, I checked. So the medical director actually records a doctor for each patient. So I printed out different patient lists for each of our doctors. I've probably put this in the wrong order. I'd already asked our doctors if they wanted to participate in an audit. And it was at the end of June, so people still had lots of CPD points to get back in 2023 at that stage. And they were mostly happy to be part of an audit like this. So what I did was just print out a list of each of the patients under each of the doctors that wanted to participate. So you might not, everyone's got different dynamics in the practice. You might just do it for yourself. But I'm a bit passionate about audit, and the practice manager is very keen on it too. And it's good for the practice to get this QI done. So anyway, and I'm passionate about dementia. So that, there's all sorts of idiosyncrasies about this. So I printed out the names of the patients who'd not received the flu vaccine. And then I asked each doctor to mark off the ones who might benefit from a recall. Now, you'd think, wouldn't you, that that list of patients would be universally benefiting from a recall. But when they looked at my list, they went, oh, that one's moved to nursing home. Oh, that one's moved out of area, gone up to Queensland to live with their daughter, because they've got dementia, it's actually a very mobile population, that population with dementia. Oh, that one's passed away. Haven't we? That shouldn't be in there, So actually what happened was, inadvertently, the 65 patients with dementia had a whole lot of data cleaning done on their records through this process. So that was an unexpected benefit. And it also made me realise that we probably need to clean our data more. we have got 2,500 patients over the age of 75. So I don't know when that's going to happen, but
That's a good point, Dimity, like the limitations of the data as well, because as you were talking just now, I was thinking about, like, if I just did an audit in best practice, it would only show me the immunizations they've received through us. So then I'd have to go into every patient, look up
that's why I had to do that.
Yeah, that's right. Like, it's so many extra steps. So yeah. So was that because I started thinking, oh, what if they got it at the pharmacist or another GP surgery, or it's just so hard
or work.
Yeah. And it's not remunerated. Like, this stuff needs to be remunerated, I think, by me, for more engagement, because it's such an important quality improvement activity. But GPs, like you said, you're doing it on a Saturday in your own time. So it's more.
And it's because
you've got
I'm
the drive
a nerd.
to do it. No, it's about caring for your patients, I think, but it's just finding that time. Yeah.
It is. Yeah, that's all true. That's all true. From time to time, the practice has remunerated me. When I actually brought this that year, it might have been the next year when we did a different audit, I actually produced the results in about November, towards the end of November. And I did ask where our senior doctor was. I asked, can't find him anywhere. And they said, oh, he's holed up in he's not going to answer the door. He's holed up in there. He's trying to do his CPD. Was it early December or something? And I brought this list and said, we just need you to, do this. What in this case it was asking the nurse to recall the patient. But obviously in early December, it wasn't this flu vaccine. It was another audit that I did for the practice. And he is not prone to being demonstrative, but he surged out of his chair where he'd been sitting like that guy there, and he gave me a hug. He's never done that before. I've been there for 40 years. So he was overwhelmingly grateful. And I did get a bit of extra money for doing that year. So, but because it is very stressful for people, especially busy GPs who are practice owners as well. I'm sure some of the rest of the audience will relate to that. You probably shouldn't, guys, give your other GPs a hug. I could have complained, but I wasn't. I took it in good part. So I'm sorry.
I see Kristen losing in the background there, because Chris knows that I'm a big hugger. So
don't get alone with Gordo. He'll corner you for a hug.
But it was actually really nice. I felt like, all those hours are worth it. So it did actually work. Yeah. So then the nurse recalled the ones that the doctor had said, yep, they need to be recalled. And that did improve our vaccination rate for people with dementia. So have you guys, I've got another bit to this presentation, so there's not going to be an awkward gap if you don't have any suggested audits, but have any of you thought about any that you like, anything, or have you done any that you'd like to share about? Anyone can speak, and I can't see your hands, so you'll have to yell.
It's Gordon here. A few years ago when I was doing my my focus psychological skills training, part of the actual training process itself was to do little mini audits and looking at your prescription kind of trends, and being able to actually look at how the patients went on different medications and if they were staying on it from looking at the data from the start of the course compared to how you were at the end of the course, which is a few months down the track. And so, so it was actually interesting to see what my go-to medications were, and if there was anyone in my actual list of patients I was recording data for, if you actually needed a swap or a change or any adjustments, and being able to monitor the actual the thinking behind what I was using, what I was doing, and if I was actually implementing any of my other psychological skills training to actually help to improve their overall mental health and well-being. And it was actually quite interesting. That was only a very, very small audit, because I think it was actually only collecting data for like 30 patients that you had seen in a kind of snowball collection effect where you just like whoever actually you saw okay, sequentially was then actually recorded in that way, and it was only for my own private reflection and therefore no actual like research um, ethics approval had to be done for that. So it was a very small kind of audit for myself. But it
Yeah.
was actually kind of eye-opening experience there, and it's like to know what age group, what kind of things was going through my mind there in regards to choosing the right therapy, and then be able to actually see if it actually worked or not, because we don't often have the chance to actually reflect on it in our busy practice.
Yeah, that's really good, Gordo.
Mm.
Yeah. And I'm doing my FPS training at the moment, and I hadn't thought about doing an audit like that. Might suggest it to the trainer. Yeah.
It's a great
And
idea, like to measure behavior change as well. Like, if you do
Mm.
intervention here or you do a learning activity and then to see, does it change practice? Like, has your practice changed over time based on that extra training you've done?
Mhm.
That's pretty cool. Yeah.
and I can see a hand up. Ah,
Ellie.
Ellie. Ellie,
Hey,
hi.
hi guys. It's such a good talk, Dimity. This stuff's so important. I
you.
haven't done GP practice audit in a while, but you guys know we run the hospital in the home program, so we run
Mm.
almost monthly audits in that, and it's been really interesting to look at our readmission rates. So we admit people for more and more complex conditions, actually. So when we took over the service as doctors 3 years ago, our team was really only comfortable managing simple cellulitis, short-term IV antibiotics, long-term IV antibiotics for joint infections and that sort of thing. But over the course of 3 years and looking at the hospital's expected readmission rates, so it's actually okay if your readmission rates to a ward bed are somewhere between 8 and 13%, and our readmission rates were super low when we started. We're not sending anybody back into hospital, which actually meant that we are taking people that aren't sick enough. So we wanted to be putting more people into hospital because we're balancing that line of, this is more and more acute. We're saving hospital beds. We're actually looking after people now that that should be in hospital. They're sick enough to be in hospital, but we're managing them at home. So we used to have a traffic light system where if you have a fever and you've got cellulitis, you don't qualify for HIF. You have to go into a hospital bed. But looking at those readmission rates now, we are actually sending about 10% of our patients back into hospital, and that's because we now take periorbital cellulitis, hand cellulitis, cellulitis with diabetic foot infections, and people with fevers and early signs of bacteremia. So that has allowed us to just gently expand our complexity and what we can do. So that's been quite interesting for us.
That's really good. So that's an audit that is also monitoring change in your practice. So that's the real even step 5 type. Go back after some period of time and see what things have changed. Yeah, it's good. It's great, Ellie.
It sounds bad, doesn't it, that we want to, have a certain failure rate, but that's, but it's been interesting to look at those numbers.
And that also brings out the complexity of picking your goal, your aim, and what you're going to measure, and what it means. Because in clinical practice, it's not necessarily black and white, is it? There's all sorts of grey areas, and obviously for you, a grey area is getting that sweet spot where you're actually saving beds, but you're not just treating a whole lot of people that could have managed with oral antibiotics or something.
Exactly. Yep.
Can see someone else's hand up there. Is it Georgia?
Jazz has
Jazz.
got her hand up.
Right. What?
Go for it, Jazz.
Joe? No? Need to unmute?
Hear me better now.
That's better. Yes, I can hear now.
Is that better? Yeah. Sorry, I had my AirPods on.
Yeah.
So I won't turn my camera on. I'm still in my
And he's dropping in and out there.
I predominantly do a lot of work around nursing homes. So I do a lot of nursing home work. And so I've reduced my GP hours and I'm actually solely doing nursing homes along with hospital in the home with Ellie. So I guess I wondered, in a nursing home specific setting, what kind of audits you can do. Because there are so many players at play when it comes to nursing homes. So I wonder, Dimity, like in your experience, what kind of audits are effective in the nursing homes?
Yeah, that's challenging, isn't it?
Mm.
I've got this one nursing home patient at the moment, and there are a lot of players. Gordo, were you going to say something?
I was actually. I know when I used to actually do a bit of work in the actual nursing home, they actually do a lot of audits themselves already, and they often disguise it in a different word called compliance. And they actually go through and say, okay, have these charts been done? Okay, for our stool charts, and our wound care side, things wise. Okay, what kind of materials are being used, and doing reviews that way. So you may actually see that a lot of these kind of audits that we are talking about, they might be actually disguised under different terms.
Okay, yeah.
The other thing would be like clinical, because I shared a NPS link as well, which talks about different steps, and I really like that first step: establish best practice standards, and so like understanding the evidence for why recommendations made, particularly if you're going to need to sell it to your stakeholders or your other colleagues and stuff later on. So things like maybe deprescribing around anticholinergic medications or vitamin D. Is there evidence that our patients should be checked for vitamin D 12 monthly or I'd be going because like what I said, there's the non-clinical stuff, but I'd be going the clinical things like, am I doing best practice for my patients admitted
So
to a nursing home?
focus more on like your own medical practice rather than the standards of the nursing home. Is that what you're saying, Chris?
Yeah, that's what I would do. Something, because you've got to be interested. If you're going to be doing this in your own time, like it's something you've got to be curious and interested enough to put the effort in to do it and see a change. Like, what is this something I can actually affect change in?
Yeah. And I think if you find something really a really topical area, like for example, falls prevention in the unit itself, everyone wants to know about that because a fall for an elderly person can be quite a significant event, resulting in significant kind of impairment in their mobility and loss of independence, and the quality of life definitely deteriorates significantly, shifting them to a much higher level of care. So there's also a lot of distress attached to not just the client, but also the family members themselves who actually have the repercussions of the fall. So that could be a very easy topic to sell to a nursing home or retirement village and see what they can do to actually optimize the safety of that facility.
Yeah, cool. And so in that situation, Gordo, I guess you're talking about using the facility to do a lot of your data collection for you.
Yeah.
It just makes that step a little bit easier because you're thinking about it from a point of view where if they can do the collection, then it means less work for you and you can just analyze that data and things like that. Gotcha.
And then be able to raise their actual suggestions and explore things together as a team and say, what can we do to look after our clients better and having that buy-in.
Yeah, interesting. Cool. That's really great input. Thanks, Chris. Thanks, Gordo and Dimity. That helps me kind of start a frame of in my head of where I would potentially start if I were to do some, which I won't. It's too much effort, but one day.
You'll be surprised. You'll be surprised because other times that they may already have data collected, but they just haven't had anyone to actually look at it. So it's because the thing is, if you look at for example, I mentioned falls. Whenever there's a fall happening in the hospital, an IMS has to be done, right? So they have a similar process happening in facilities for aged facilities, and so therefore, if there's already information in that system there, and we've got this already recorded, it's looking at it, oh, how many falls are there, and what kind of falls are we talking about? Is it a certain location here? Is it actually in the actual bathroom facility where it's a wet ground, or is it actually more in the actual patient's rooms and they're coming out, emerging from the bathrooms, or is it just simply any trip hazards that we know about that we can actually do? So this brings in your health and safety. They will be really, really keen to find out more.
Yeah. Okay. Yeah. Thank you. Thanks so much.
Okay, that was good. I can see you're getting your audit hats on. Georgia.
I was just going to comment that we've got so many tools now to data collect. So Ellie's made a comment about, you can review your MBS billing habits, and we have Cubico, so it's really good to, you can just plug in a few numbers and it comes up with, how many patients you bulk bill versus private bill, how much percentage of your chronic disease management are you doing. There's also PenCat to bring up other things. There's just so many quick little tools that I think we're sort of using a lot of these without realising that we're sort of doing little almost mini audits. So
Yeah.
I think you've inspired us, Dimity, to go that extra step.
All right, I'll show you my last few slides. It's an example from the UK. And this was in a letter to the Australian Journal General Practice in June this year. So you can look it up if you want to. So so it's nice that British GPs are reading our AJGP, I must say. So in 2024, 4 medical students undertook a second round of audits in this inner city practice. It was a disadvantaged practice. I haven't put all the details in. I guess the GPs are probably people that are really interested in perhaps looking at things in more depth, working in a practice like that. So they got these 4 medical students to look at diabetes, chronic kidney disease, UTIs and ADHD, and they had all previously been audited by other groups of medical students, so they knew what the answer to the questions were a few years before, and so and the practice manager helped, and they evaluated against NICE guidelines, which are the UK guidelines. And if you have a look at the bits in yellow on this table, you can see that for diabetes in the first audit, 44% of women had their hemoglobin A1C checked. In the second audit, it had gone up to 56%. So there weren't any fancy P values or anything done, but there was an improvement. And similarly for CKD, they were looking at having EGFR measurements taken and no coding of CKD, and they found that 64 patients weren't coded as having chronic kidney disease in the baseline audit, and in the follow-up audit in 2024, only 4 were not coded as chronic kidney disease. So that was hitting the list of their conditions, and that does trigger us sometimes to get reminders of when we're doing prescribing about people's conditions. So that's actually really useful. And then there was ADHD. Well, obviously we're moving into prescribing ADHD medication more now, but they needed to have a certain number of parameters recorded, namely height, weight, blood pressure, and pulse in the last 6 months. And at baseline, only 13% of those had those, and it had gone up to 25%. And these for people, young people taking stimulants. And then lastly, antibiotic treatment. They do a 3-day course in the UK for uncomplicated UTI, and that also improved. You could perhaps argue about that, but I don't know how they were diagnosed. I haven't got that written down there on that. And it was only a letter, so I don't know that information was there. But what they said was, because the findings were positive and things had improved, the morale and the motivation of the GPs was improved, and also having the students there. The obviously GP practices in the UK also get paid for having students, just as we do through the PIP. So there were 2 positives for the practice out of that. And not only that, but the students really felt as though they were making a difference. And all 4 medical students are now considering becoming GPs. So I thought that might appeal to our audience who are always looking out for people to become GPs. And that's part of our project, yeah. Sorry.
What a great use. Sorry to interrupt you. What a great way to use medical student, like not use, just like to give a task
Involve
to a medical
them.
student. But you know what I mean? Like, 'cause
Yeah.
part of this whole thing is GPs go, oh, this is so much work. When do I have time to do this? But it's that thing of, well, how can you delegate to either med students, practice, you know, to help with this data collection? And then same with when you find a change, how do you change processes that will in the long run actually help you and your workload and your cognitive load? So if you can delegate a task like checking a HbA1c in a patient to a practice nurse, or you know, or another task to another person in your team, that's less stuff you have to remember and also improves quality of care. So it's that whole thing of how can we, but I love the idea of giving a medical students a little project to do during their, you know, 16 weeks or so that are at the practice. But sorry, Jazz had a question too.
Yeah, sorry, Dimity, I just had a quick question. I don't know if you touched on that, but is there particular templates that you're using to then like formalize your audit? Like, how do you document it? Are you using an Excel? Are you then like putting your findings? Like, where are you actually storing the information? How are you doing it?
I actually just did a table like that one, but
then in terms of your findings and things like that, like, so when you're putting in for the RACGP, is it then just in your head that, oh, these were the findings, or are you actually like documenting your findings somewhere? Are you like, so that you can come back to it next year and go, oh yeah, we did this audit and these were the findings, and this is like, how do you actually do that?
The CPD handbook, which you can easily find online, has some guidance about how you record things, but so that's one thing, but it's pretty broad, and you are quite right. It would be really good to keep records of this, so that, and obviously this practice did, because they had the first audit findings and they could put in second audit findings, and I haven't been doing that. So that is a really good point, especially for that.
But there's nothing like you guys doing. Yeah, but there's nothing like at the moment, Gordon, Chris, or anybody who does audits regularly, like you're not keeping like a Word document that has like a nice little summary of your audit. Does anyone do that, or do you just do your audit and then you have it in your head, oh, this is what we found, and then you get your CPD points and move on?
Well, you have to write it down.
Yeah, and you have to keep evidence. There isn't evidence. There's a table for CPD that has the evidence requirements for your trienniums, and like, so I don't know about everyone else. I would just have a folder on my own desktop, making sure it's all de-identified, like Excel sheet, you know, audit, whatever. But I think within the practice standards, there are standards around, if you're doing it as quality improvement, of having a practice team member who's responsible and who, you know, documents meetings and minutes, and like, if you're going to get official about it, you have a proper system, and then there would be a practice-based storage of information and those minutes and stuff like that. So it depends. There's a whole level, like there's a whole spectrum of how seriously you take this. But personally, I would just have my own data. But it's like, the key is that it's de-identified. Like, because when you do your in best practice, when you do an audit, it has the patient name, so you've just got to be really careful not to print that off. I'd be doing de-identified Excel sheet with, you know, patient 1, 2, 3, 4, 5, 6, 7. I mean, that's common sense, I guess, but
cool.
That's good though, Chris. Next time I do this talk, I'll make sure. And that was a great question. Thank you, Joe.
Thank you.
I'll make sure to include that in it. So I think that was it. Yes, I added in down the bottom, positive engagement amongst staff and students is a practice outcome. That's really good. And those are the 4 steps again. Okay, thanks, guys.
Oh, thank you so much, Dimity. That was great. You've inspired us. And I think we'll be all putting our thinking caps on and see how we can, improve our practice. And certainly since we had discussions over the last few months, Dimity, we've certainly noticed, I've had a few patients with dementia that they come in and I'm like, oh no, you haven't had your flu vaccine. So it's, you've hit the nail on the head there, Dimity. So thank you so much, everybody. That was